Hospitals have been frustrated for many years about the various rating systems that are used to rate them. U.S. News & World Report, the CMS Hospital Star Ratings, and others. And recently there's been a push to help improve how the CMS star ratings, in particular, are constructed. Why are hospitals so concerned about the ratings? Well, there are a number of reasons. First of all, it impacts their volumes, the number of patients they see. One study has shown that improving by 1 spot in the U.S. News & World Report national ranking results in a 1% increase in volume, and that U.S. News rank changes are responsible for 5% of the variation in hospital volumes overall. Ratings also impact outcomes because if the rating systems aren't accurate, if high-quality hospitals are rated poorly and low-quality hospitals are rated well, then patients can end up choosing worse hospitals than they otherwise would. Ratings also give hospitals incentives to improve, which is good for the health of our communities. So ratings have a potentially significant impact on public health. Ratings also affect the reimbursements that hospitals receive for their services. That happens for at least 2 reasons. One, more highly rated hospitals are able to attract patients with better paying insurance. And 2, a hospital that is more highly rated is able to negotiate better reimbursement contracts with private payers. Lastly, ratings affect physician morale. Imagine being a physician who cares deeply for your patients and is devoted to providing the best possible care and to saving people's lives. If you're in an organization that is rated lower than is deserved, it can be demoralizing. Imagine how a student would feel after failing a class for which they felt they deserved an A. To understand the problems underlying hospital ratings, you first need to understand how they are calculated. The different rating systems are based on different collections of measures. Overall, there are 2 kinds of hospital measures: process measures and outcome measures. The process measures are really measuring the adherence to various protocols that the medical community believes represent best practice. For example, there are detailed protocols for how sepsis should be treated, evidence-based guidelines for treating patients arriving to the ER complaining of chest pain, and so on. Process measures assess a hospital's adherence to these guidelines. In contrast, outcome measures assess the results that patients experience from their care, such as readmission, mortality, or patient safety events. These measures are important not only for the various rating systems, but also because they're used by the Centers for Medicare and Medicaid Services in different programs that it runs, such as the Hospital Value-Based Purchasing Program, the Hospital Readmissions Reduction Program, and the Quality Payment Program. These programs significantly adjust the reimbursements that hospitals received based on these measures. But one of the fundamental problems with hospital ratings is that the data underlying these measures are inaccurate and incomplete. Not all hospitals report all the possible diagnosis codes that may apply to a patient, and as a result, there's an inaccurate representation of how sick or healthy patients at those hospitals really are. The data on socioeconomic status that hospitals submit are also limited and not standardized across the country. The only data point used to adjust these measures for socioeconomic status is whether or not a patient is dual eligible, which means that a patient is eligible for both Medicaid and Medicare. But more refined indicators of socioeconomic status, do they live alone, do they have access to transportation, and so on, which do impact readmission rates and such, to date are not included in these rating systems and financial incentive programs. Another problem is related to how the measures are actually used and calculated. If you look at measures like mortality and readmissions, clearly they depend on the mix of patients. So when you're comparing 2 hospitals together, if one hospital has a very, very sick and complex patient population, and the other has very, very healthy patients, their raw mortality rates are going to be different. You need to adjust those mortality rates to take into account the health of the patients, a process called risk adjustment. It turns out the methods that are used for risk adjustment, in particular, a popular method called indirect risk adjustment, has inherent bias in it in terms of being very sensitive to the mix of patients a hospital sees. So this can be unfair for hospitals. A final issue I'll point out is how the various measures are weighted to compute an overall composite score for a hospital. These weights are either ad hoc or based on methods that have foundational problems. To illustrate, let's focus on the CMS Hospital Star Ratings, which have been released biannually since July of 2016. They provide a simple way for consumers to compare hospitals. They assign each hospital between 1 and 5 stars, with 5 stars being the best. In December 2017, 3,692 hospitals were publicly rated. The ratings were based on 57 different measures, which are broken out into different categories: mortality, readmission, patient safety, patient experience, effectiveness of care, timeliness of care, and efficient use of medical imaging. These categories correspond with consumer perceptions of hospital quality. When choosing a hospital, patients ask, will I die? Will I be readmitted? Will I be safe? Will I have positive interactions with medical staff? Will my care be timely, etc.? These different categories are then weighted to come up with an overall score for each hospital, and then the scores are used to rank the hospitals, with the hospitals that score the highest getting 5 stars and the hospitals that score the lowest getting only 1 star. There seems to be some consensus on the weight each category of measures carries in calculating a hospital's overall quality score. So for example, mortality represents 22% of the total score. However, within each of these categories, there can be 7 to 11 different measures, and it's unclear how to weight each underlying measure. For example, the mortality category includes 30-day mortality measures for patients having heart attacks, coronary artery bypass surgery, heart failure, stroke, and pneumonia. How should these be weighted? The group accounts for 22% of a hospital's overall score, but how should the 22% be distributed across these measures? There are 2 basic approaches to how you might go about coming up with these weights. One way would be to set them a priori, fix them up front. This is the way school works. A professor on her course syllabus will announce to the students on the first day of class how the various assignments, quizzes, and exams are weighted to compute the final grade for the class. For hospital scoring, this has the advantage of allowing hospitals to know what to best focus on, because they know what measures are going to have the highest weight. On the other hand, achieving national consensus on what those weights should be is very difficult and unlikely. Another way to do it is to come up with weights ex post. So back to the school analogy, instead of announcing what the weights are going to be up front, the professor instead tells the students what homework and quizzes and exams there will be, and at the end, after everyone has completed all the work, then she decides what the weights will be. Now this seems ludicrous because how can the students plan if they don't know what the most important components of their grade will be? Students would also be concerned that the weights will be determined in some arbitrary or biased way. To alleviate this worry, the professor could tell the students up front what the algorithm for determining the weights will be, but without knowing everyone's grades, it is practically impossible to predict the weights it would compute. This second approach is how the CMS currently computes the hospital star ratings. The downside is that hospitals are in the dark about which measures are going to be weighted most heavily, but the advantage is that it gives the CMS the flexibility to add and subtract different measures as new measures come out and old measures are improved. The algorithm that the CMS uses is based on what's called a latent variable model. This kind of model posits that there is a single hidden factor that drives performance across all the measures within a category. So, for example, within the mortality category, the model assumes there is a single factor that drives mortality for heart failure patients and for pneumonia patients and for stroke patients, even though those patients are interacting with different doctors in different parts of the hospital organization. This approach assumes that one measure oriented towards surgeons in operating rooms and another measure oriented towards internists on medical wards are both driven by a single latent quality factor, even though in practice these doctors and departments operate relatively independently of each other. Each group of measures has its own latent variable, and the score for a group equals an estimate of this single hidden factor. Higher weight is placed on measures that are deemed to be more strongly correlated with this hidden factor. Now, you can't measure this latent factor or even prove that it exists, so how can it be calculated? Well, what you can do is look at the correlations between the measures themselves, how a change in one affects the value of another. If 2 measures are more strongly correlated, then there is a greater likelihood that they're being driven by the same factor. Whereas if 2 measures are not correlated or are weakly correlated, then it's less likely that the same factor is driving both of them. Thus, the approach relies on exploiting correlations between measures. The problem is, the assumption that there's only one hidden factor within the group is not well supported by the data. And as a result, the weights placed on various measures can exhibit unstable behavior from year to year. Some measures can be effectively ignored altogether. This has been a source of frustration for hospitals for many years. To see what I mean by instability, let's look at the safety of care group. In this group, there are a variety of different measures involving, say, urinary tract infections, central line infections, MRSA, a measure called PSI 90, which is a composite score of patient safety, as well as complications from hip and knee surgeries. Over the years, you see quite a bit of fluctuation in how these different measures are weighted. You see this in the measure loadings, which represent each measure's correlation with this hidden factor. A higher loading means that a higher weight ultimately gets placed onto that measure. For example, in the dry run that was done in April of 2015, measures of MRSA and an infection called C. diff, for short, had very low loadings and so weren't very important for computing the score for the safety of care group. Then, in July of 2016, their loadings jumped up quite a bit higher. In the following year, they dropped down close to zero. In December of 2017, most of the weight in the safety of care group was placed on the PSI 90 composite measure. Then, in July of 2018, just before the next series of results was released to the public, hospitals were given a preview of their ratings, and they saw that the weight actually had shifted from PSI 90 almost entirely to complications from hip and knee surgeries. As a result of that, hospitals that were doing well, even if they improved on all measures, ended up being rated lower because so much of the weight shifted spontaneously to this other measure, on which they may perform worse relative to PSI 90. On top of the instability, this is counterintuitive. PSI 90, where the weight had been placed previously, is a composite score that impacts almost all hospital patients. In contrast, complications due to hip and knee surgeries only affect patients that are getting special kinds of orthopedic surgery, which is a much smaller population. Not all hospitals even do hip and knee surgeries. So to peg so much of a hospital's ratings to just those procedures really makes little sense to hospitals. What causes this instability? Well, suppose I give you 4 measures, A, B, C, and D. A and B are correlated with each other, and C and D are correlated with each other, but there's no correlation across these two groups. So neither A nor B is correlated with C or D. Now, clearly, it can't be the case that all of these measures are driven by the same hidden factor, because if it were, and that hidden factor were to improve, then you would see an improvement in both A and C simultaneously. But you don't see that in data because they're not correlated. As a result, the model will place all of its weight either on A and B or C and D, but not both. That's what I call a knife edge. If the correlation between C and D becomes infinitesimally larger than the correlation between A and B, then all of the measure weight will shift from A and B entirely to C and D, so that suddenly A and B don't matter anymore. Thus, a tiny change in the data can result in a cataclysmic change in the way the different measures are weighted. The problem with this, of course, is that consumers, patients, still care about A and B. A and B may be very dangerous infections that occur in the hospital or mortality for different patient groups. And so patients do still care about A and B. However, because the method only exploits correlation, measures A and B can be completely ignored, regardless of how many patients are affected by them. There are 2 basic principles that I believe a hospital scoring system should exhibit. Number 1, hospitals should be evaluated based on how they compare to the best performers, regardless of the statistical correlation between the measures. In fact, I would argue that the best set of measures for scoring a hospital would be ones that are weakly or not correlated, because they would measure different parts of the hospital. If you wanted measures to be highly correlated, you could look at just cardiology patients. Those measures would be more likely to be correlated because care is provided by the same clinical teams. But if we're looking for a way to score hospitals overall for use by the general population, we would like to have a more comprehensive view of a hospital's performance. The second principle is that between 2 measures that have the same clinical relevance to a patient, the one that has the potential to affect more people should be weighted more heavily. An example of this is the PSI 90 composite measure, which is computed on a population of patients that is much larger than the measure of complications due to hip and knee surgeries. On that basis, PSI 90 should be weighted more heavily. In a recent working paper of mine, I developed a new approach to scoring hospitals based on these 2 principles. Here's the way it works. Suppose we have only 2 measures instead of 57, so we can visualize these 2 measures on an XY graph. Each point on this chart represents a hospital, and its location on this chart represents how it performs on measure 1 on the x-axis and how the hospital performs on measure 2 on the y-axis. Given this collection of hospitals, we may ask, which of these hospitals is the best hospital? The answer is unclear. It could be the one on the bottom right. This hospital performs the best in terms of measure 1, but it performs the worst for measure 2 amongst all the hospitals. On the other hand, we could consider the hospital on the upper left. That hospital performs the best along measure 2, but the worst amongst all hospitals for measure 1. Other hospitals are well behind along both measures, and so we can exclude them. This leaves us with 2 other hospitals for which One of them performs better than the other on one measure, and vice versa. And so which you deem the better hospital depends on how you weight the different measures. If it existed, the ideal hospital, which performs the best along all measures, would be a hospital you could compare against. The problem, though, is that the ideal hospital doesn't exist, and so comparing against it would be unfair. If we had weights for each of the two measures, we could take a weighted average of them to come up with a score. We could declare the hospital with the highest score to be the best hospital. Clearly, though, this determination would depend critically on how the weights are set. Here's how my method works. First of all, get rid of the idea that we're going to weight the different measures using the same universal set of weights for all hospitals. Instead, suppose we want to evaluate Hospital A. Hospital A will have weights that are computed just for Hospital A. So every hospital will have its own weights. Now you might say, wait a minute, this seems unfair because every hospital gets its own weights. However, I'm going to compute these weights so that each hospital's overall score is as high as possible. Furthermore, every hospital will be subject to the same constraints on those weights, which are related to how many patients may be affected by one measure versus another. So we're going to compute weights that pertain only to Hospital A, and we're going to measure the distance between Hospital A and what we'll call an ideal hospital. We'll make that distance our yardstick, but we will not compare Hospital A directly against the ideal hospital because it's not a realistic point of comparison. Instead, we construct what's called the efficient frontier. This is the outer envelope of performance across all the different hospitals. Given this, then we can construct a virtual hospital, which is at the point where our yardstick intersects the efficient frontier. This virtual hospital makes a reasonable comparison in the sense that, by construction, it is better along every dimension than Hospital A. Hospital C, for example, makes a less ideal comparison because while it performs better on measure 1, it performs more poorly on measure 2. At the same time, the virtual hospital is a hypothetical hospital that represents more realistic performance because it's a convex combination of hospitals B and C, which are real hospitals. Now that we have this virtual hospital, we need to compute the weights for Hospital A. We do this so that the score of Hospital A is as close as possible to this virtual hospital under the same set of weights. In addition, there are other constraints on how weights are set. If one measure covers 3 times as many patients as another, then, assuming they have the same clinical significance, the first measure should be weighted at least 3 times as much. We also normalize the weights, make sure they add up to 1, and ensure that a hospital's overall score is as large as possible after normalization. There are only 2 measures displayed in this example chart, but in practice we compute weights for 57 different measures. Other constraints ensure that the total weight given to each group equals the group weight determined by the CMS, 22% for mortality, and so on. Using the overall hospital scores, we can then rank all the hospitals and determine how many stars to assign to each hospital. There are several different properties that my approach satisfies. One is that under reasonable conditions on the data, improving hospitals improve their scores. That is, if a hospital improves along every measure relative to every other hospital, it actually scores better. Secondly, infinitesimal changes in the data can only result in infinitesimal changes in the score. So you can't have a spurious correlation that then results in a cataclysmic shift in the scores. Lastly, there's a domination property, which means a hospital that performs better than another hospital along every measure ends up with a higher score. This property is common sense, but in the current CMS approach, this property can be violated in some circumstances. Using this efficient frontier approach, I've recalculated the score of every hospital in the United States that CMS rates, allowing me to compare my proposed approach against the current CMS approach. One important observation is that under both approaches, larger hospitals rank lower. This occurs for 2 reasons. One, larger hospitals tend to have lower values on key measures. Why? For one thing, larger hospitals tend to be in urban areas with patient populations having lower socioeconomic status. However, 30-day hospital readmission rates, for example, do not account for socioeconomic status, even though it is known to have a significant impact on the likelihood of hospital readmission. Also, because larger hospitals provide larger sample sizes than smaller hospitals, poor performance along a given measure counts worse for them than for a smaller hospital. The second reason big hospitals rank lower is there's a crowding out effect. Larger hospitals are lumped together with smaller hospitals in computing the ratings. If the smaller hospitals perform better in overall scores, in the final ranking they will crowd out the larger hospitals. If we divide all ranked hospitals into quintiles and compare the CMS approach with the efficient frontier approach, I find that larger hospitals are more likely to stay in the same quintile than smaller hospitals. In contrast, among critical access hospitals, which are small rural hospitals, about half of them change quintile. That's because hospitals, and in particular the critical access hospitals, do not report all measures. For example, critical access hospitals do not report PSI 90, which has the highest weight in the latest CMS release for the patient safety group. However, they often report their C. diff infection rate. But even if they have an alarmingly high C. diff infection rate or a remarkably low C. diff infection rate, their performance on this measure is basically ignored, and the hospital is effectively given an average score for the safety of care group. Under my proposed approach, the weight for the group is all shifted onto the measures that are actually reported, yet another advantage of giving each hospital its own set of weights. And so in this example, the 22% weight on the safety of care group will get shifted onto the measures that are reported. Thus, my proposed approach rewards hospitals that do well and penalizes hospitals that don't on the measures they actually report. Rating systems have a big effect on the competition between hospitals and the financial performance of hospitals. However, rating systems are flawed along various dimensions. Thankfully, there are some potential fixes along the way, and CMS is working on implementing improvements. US News & World Report is always trying to improve as well. Over time, hospital performance measures will become more accurate, the data that go into them will become more complete and representative of patients' true health statuses, and hospital scores will be computed using better methods. This will give us a system for rating hospitals that allows patients to have better, more accurate information to make choices, and as a result, competition between hospitals will be based on more realistic assessments of hospital quality and performance than it is today.